operation cases. This is a typical MCI cases, 81 years old, and eyes closed. You can see here, the doctor labeled this patient as the mild cognitive disorder. And we can see the data, raw data here. And this is the clean data. First thing we can see is the T5 has largest alpha activity. I think it is largest, not O1, O2. T5 alpha, T5 oscillation is largest in this case, I think. So this is the clean data. This is not so. This could be a real signal. No. This is the clean data, and we can see the component here. We have the first component is the middle temporal, and you can see here the T5 and T6. Usually, first component is the largest effect in the sensor level EEG. The power of the component. The first is the 80, and second is the 50. Something like this is more power, but the power usually the integration of this under this curve. So yes, so the peak is important, but all the area is the power. Yeah. So the first component is the largest effect in the sensor level EEG, and usually the normal healthy population, the occipital alpha peak should be component number 1, but these MCI cases, you can see the first component coming from the middle temporal gyrus. So X equal 40 is the right hemisphere, Y equal 5 is almost in the center, just above the center line, a little bit frontal, just 5 millimeter above the central line. And the jet score is under the horizontal line, very low position. And you can see this is the right temporal area coming from this kind of low frequency theta and alpha activity coming from very deep in the right temporal area, but the projection is the posterior direction. Projection is the posterior direction, so we have the largest amplitude in the T6 in this case, but we have the T5. I see the T5 a little bit larger, but T6 is larger here. But we combine all the components to make the sensor level signal, so we have to look another component too. In the second component coming from the left, minus 30 millimeter, and right, this is the posterior area, minus 30, and that is 20 is above the horizontal line. So right posterior area, so right posterior area, and the projection is this direction. So we have the largest amplitude in this area, but coming from the posterior insula. Yeah, so we have the largest amplitude in P4 and T5 in this case, but coming from temporal area. Insula is another kind of temporal structure. So we have both temporal. You can see the alpha, and this is the slopes. This is the theta. So this both temporal area starting the theta rhythm in this MCI patient. And another one is the right posterior alpha activity, slow alpha. Alpha is not so fast, but this is the quite close to the Brodmann area 19 is the visual cortex. But actually, the parahippocampal also close to the parahippocampal gyrus. So it is also kind of close to temporal source. And another component is the frontal. You can see this is the frontal right frontal, very high position, jet is 70, and the projection is a little bit behind. You can see here, with posterior direction. So we have this positive projection and the negative projection. The source in the middle of the blue and negative projection and positive projection. Source is between here, between this yellow and between this red and blue, because this is the dipole projection in both directions. So this is the frontal component. The temporal and frontal component is not so healthy. Usually the alpha component should be coming from the back of the head, but temporal and frontal slowing activity coming from this is the lingual gyrus. This is the usual occipital area. You can see the y equal minus 90, very posterior area. In the central, the x equal minus 10 is the central left, and the very posterior area, and jet is just under the horizontal plane. That's the usual alpha activity. This is the healthy alpha activity, but prior to healthy alpha activity, there are a lot of unhealthy alpha and theta activity in this MCI patient. And this is the component we can see for the MCI patient. And another one is the fusiform. The minus means the left posterior and below the horizontal plane. So left posterior area, there is a source here, and we can find another temporal alpha activity coming from here. So, and we also can see the this is the very close to the center, and we can see the very slow activity. This is the theta and alpha activity at the frontal. We can see the projection of this component in the frontal and central area. Frontal central slow wave. You can see in the component 7. And another one we can see is the temporal alpha activity, T3. Coming from pre-central area, the left central area, and projection is temporal. And you can also see the cingulate usual alpha source area, but there are a little bit slower theta peak is here too with the alpha activity. And superior temporal source, but the projection is a little bit anterior. So we have the largest amplitude in the frontal, in this frontal area. Coming from y equal 5 is just posterior, just anterior position but projection is anterior direction, so we have the largest amplitude here. So we have a lot of temporal dipole source, and projection is frontal or temporal. So we can expect she has a lot of frontal or temporal slow activity. And another one is the usual parietal alpha source. So this is another frontal slow activity. And this is the eye blinking and the central alpha activity. And also we can see this is the detected by the frontal eye movement, maybe. We can see the time series here. The component number 15, number 13 will be rejected, and number 15 is also rejected. This is the very combination of the eye blinking and another activity. There are a lot of eye blinking activity, number 13 and number 15. So it is rejected by AI as an artifact, but eye blinking artifact, but T4 is not that artifact area, but it is combined the eye blinking activity and another two mixture of the different kind of oscillation. But eye blinking, due to the eye blinking, it is rejected. And there are similar source coming from frontal and temporal. She has a lot of frontal temporal slow component. Finally, she has this kind of activity. I think this is coming from the PF4. You can see here in the clean data. We have this oscillation. I think this should be rejected. This remaining artifact. After rejecting this, I think here is 2.
So opening, isn't it?
Yes, we need to reject this too. So I have another. This is automatic rejection, and this is the manual rejection. The same data. I rejected that portion. So finally, I have this one. A little bit remained, but the major finding from her EEG is the temporal, both temporal slowing at 6 Hertz excess and 7, 8 Hertz overall excess. 8, 9 Hertz frontal a little bit excess and a lot of deficiency in the beta and gamma rhythm. And this is the typical case. I think this is typical case of the MCI before the dementia. And in the relative power, we can see the similar pattern. And then we can also see the spectra. You can see the usually the O naught should be greater, but in this case, T5 amplitude is the larger amplitude here, and this is the abnormal sign. And another abnormal sign is we have the alpha activity and the slow alpha activity. We both have the alpha and theta activity. Alpha start to decrease in the theta region, and we can see here, and we can click the frequency. the peak frequency alpha is the 8.5, but the second peak is the 7.25. So she start maybe the doctor labeled her as an MCI, but the developing this is the prodromal stage of the dementia, and we can also see the two different peaks in the frontal too. You can see in the frontal the same peak, the 7.25 and 8.5. So the alpha decreasing and theta increasing. Usually the highest theta in the temporal area, in this case T5, and that's the typical MCI cases. And we can also see the theta beta ratio is very high. This arrow means that this area is the largest theta beta ratio, accessing this cutoff value. If just in case there is no arrow, that means all the red value is below the 1.96. But just in case, like here, we have the arrow means this is the maximum theta beta ratio, and the value is above the 1.96. This Friday, we will update our web service. In that update, there will be a G-score value here. G-score value of this kind of you can also see that there are a lot of arrow here, and we can give the G-score here. The average G-score, prefrontal average G-score of the frontal.
That's wonderful. I know that's something Manuel Halter has been asking for, so that's awesome.
Yes, that's the our next release in this week. We'll update this G-score numbering, and we can see the theta alpha ratio is largest in the theta is alpha is decreasing and theta increasing, so that's why the theta alpha ratio is largest in this left temporal and the right temporal area. Left temporal is more bigger value, so that's why the only arrow is here. Largest value area, we added the arrow. And in the connectivity, we can see there are a lot of delta hyper connection in the right temporal area and the left posterior area. In the theta, there are a lot of hypercoherence, right frontal and left parietal, and between the right occipital and left parietal. This is the largest hypercoherence. And alpha, there's also a lot of hypercoherence. And we can also see in this source activity in the 3D mapping. And here we can see the 3D map. I think you can see the lot of theta in the left compared to the right. Left theta absolute source activity is more deviant.
Dave,
right?
Can I ask something?
Yes.
In fact, like looking at the delta connectivity, there was
Yes.
a lot stemming from the posterior right temporal region.
Yes.
Could that also relate to previous head trauma?
this kind of high hypercoherence, right?
Yeah.
In the delta.
Yeah.
Yeah. I'm not sure, but this connectivity, I have to ask the doctor
Yeah. Okay.
of her history.
Yeah.
If there, I need to check the patient history, whether she had a head trauma,
Yeah. Yeah.
but could be, I
Yeah.
think.
'Cause by the time you get to be old, you've bumped your head many times.
Yeah.
I just wonder if a lot of our dementia presentations don't relate to years of
I see.
many bumps to the head as well.
In this case, right left occipital area,
Yeah.
the delta connectivity
Yeah.
and theta connectivity is very high.
Yes.
So that's why we need to check this area
Yeah.
of the pre-TBI history.
Yeah.
And I need to check with the doctor for these cases.
Mm.
And we can see the activation in the theta like this.
Yeah.
In the relative power, you can also see left is this is left and right. In the relative, they are very similar, but in the relative, the frontal area we can see the absolute theta activity in the left here compared to the right, but in the relative, I cannot see this big difference between left and right. I need to go back to the what is the absolute and relative? Yes, in the absolute, we can see the clear increase of the theta activity here.
Yeah.
But in the relative, we cannot see that kind of big difference in the theta activity. That's why we have in the source, the left is more clear. But left and right is both having the problem in this case, but you can see the left problem more clearly in the absolute power, like this. And alpha activity, slow alpha. And we can see the slow alpha activity, the left frontal. Left frontal
strip.
yes, left frontal and left temporal is more problem.
Yeah.
And you can see in the left in the source left is a little bit problem, but we can see in the component there are a lot of temporal theta activity starting and temporal alpha also there, and some small frontal slow activity source. We can find a lot of temporal slowing starting in this MCI patient, and we can have that kind of common finding of the MCI in these cases, and we can understand iSyncBrain component and various topomap and spectra and power ratio and source connectivity and source topomap in the 3D. And also we can see the MCI value for this patient. And she has 68%. So This is the MCI before the dementia. So we can use this kind of iSyncBrain features
Fantastic.
for understanding MCI.
Mm.
I think that this is the brief iSyncBrain introductory material for understanding MCI. And so I have another interesting cases of the young girl who have the moderate depression. I'd like to continue the another case for understanding iSyncBrain analysis. Do you have any comment before?
Can I? I know I talk a lot, and I'm sorry, but just
No.
the spectra itself, the spectra map that you have there. Is it possible to use brighter colors with that? Because we often put that in reports for people, but it doesn't come up very well. And if we could use brighter colors, I think it would look a lot better.
For example, here, the spectra, you say, this color is not so good, you mean?
It's not bright enough.
It's not bright.
It comes out very plain on the reports. It's beautiful, but I just wondered, do we go too high up to 80 there? If we could take that down to 50 and expand this more so that it's more visible, the shape of the power. I don't know if it's possible or not, but I know that's separate to what you've just shown us, which is fascinating. Yeah.
You mean this red and blue color? Changing the red and blue color to the bright one?
Yeah, and reduce the graph to only to 50 here, to 50 hertz, right?
Yes.
So that you get more of this in the graph, more of the actual shape of the power in the graph. Or is it
for example, this is the dB scale. You can see a lot of you can also see the detailed change of the high frequency activity. We offer the dB scale.
So how do I change that? Because I haven't done that.
Really? You can choose these two.
Yeah, okay.
This is the linear amplitude.
Yeah.
And you can see 0 to 80 in this case, and the dB cases. dB unit, you can find the
that's
0. Yes, 0 is 1 microvolt.
Yeah.
-10 is 0.1 microvolt. -20 is 0.01 microvolt. So you can see a lot of fluctuation in the high frequency oscillation.
Okay.
And
yeah.
In this case,
that's beautiful. Yeah, that's much better.
Yeah. And I usually for finding the abnormal peak amplitude, the linear spectra, we can easily find which is the biggest.
Yeah, I see.
But for finding the high frequency activity more better, we need to change the dB scale.
Yeah, I get you.
In the dB scale, we can see the high frequency activity, and also we can see in the relative power. In the relative power, we can change the scale here. And change the scale.
Okay.
In the absolute power, you can also change the scale like this.
Beautiful. Okay.
80, from 80, 40. Oh, this is not changing here at the moment. I need to check why this is not working.
Okay.
I need to check. But usually relative, you can see the
You can
different.
Yeah.
Yes.
Very good.
And usually we, I think there is only 10 minutes left. I think we need to review the depression cases in another meeting, and we can prescribe the polar biomodulation in this case. For example, the alpha frequency a little bit slowing here, 8.5. So we need to speed up of alpha frequency. Is kind of brain brightening protocol in the neurofeedback. So we can add, for example, 10 hertz alpha PBM for this old woman. Then we can make the alpha a little bit higher to have good information processing speed. I think in this MCI patient, we can start the PBM for the patient, and we can monitor the change of the progress using the monitoring QEEG. So
Excellent. Mm.
in this case, we can start the 10 hertz stimulation like this, global 10 hertz stimulation, maybe a little bit. Her alpha frequency is currently 8.5. 8.5, and 10 hertz is a little bit deficiency, showing the deficiency, so we can tune up all the brain oscillation in more fast rhythm.
Very good. Yeah.
Yes.
And after that, after she started showing improvement, would you increase then to like 12 hertz?
Yes, we can just a little bit
At a
tuning
time.
the frequency.
Yeah.
After we finding some kind of efficacy.
Mm. It's beautiful.
So I think that's the early screening of the MCI using the simple scan, and then we can once we can find the MCI people, and then we can start speeding up their temporal theta and global slow rhythm using the PBM, and then monitor their progress. Then, in our experience, we can recover the MCI in 12 weeks PBM 3 times a week and 10-minute a session. This kind of high frequency alpha PBM, or sometimes the SMR PBM also benefit their sleep quality and speeding up their slow brain oscillation. So combination of the iSyncBrain, iSyncWave scan, iSyncBrain MCI, and this kind of analysis and finding the location and then target that location. In this case, the global slowing. So we applied a little bit high frequency PBM. That kind of seamless scan analysis and PBM and the monitoring that makes the, for example, 12 weeks intervention make the MCI people more healthier. So that's our POC result last year. So we are now starting the KFDA approved clinical study for tPBM efficacy of MCI population in Asan University Hospital, the in the five major university hospital in Korea.
Oh, fantastic.
Yeah.
Fantastic.
After that, KFDA temporal biomodulation, QEEG guided biomodulation efficacy study for MCI population that will make big changes.